Okay, superficial punctate keratopathy. Symptoms: patient may present with pain, photophobia, red eye, foreign body sensations, mildly decreased vision. Signs: critical, pinpoint corneal epithelial defects that stain with fluorescein. May be confluent if severe. Staining pattern may allude to etiology. Pain is relieved by the installation of anesthetic drops. Etiology: superficial punctate keratopathy is non-specific, but it's most commonly seen in the following disorder, which may be associated with a specific staining pattern. Superior staining, normally caused by contact lens related disorder, for example, chemical toxicity, tight lid syndrome, contact lens overwear syndrome, giant papillary conjunctivitis. Foreign body under the upper eyelid, typically linear SPK, fine epithelial defect arranged vertically. Floppy eyelid syndrome, extremely loose upper eyelid that evert easily. Superior limbic keratoconjunctivitis, SLK. Vernal conjunctivitis, atopy, large conjunctival papillae under the upper eyelid and or limbus. Interpalpebral staining, dry eye syndrome, poor tear lake, decreased tear breakup time, decreased Schirmer test. Ultraviolet burn or photokeratopathy, often in welders or from sun lamps. Inferior staining, blepharitis, erythema, telangiectasia, or crusting of the eyelid margin. Exposure keratopathy, poor eyelid closure with failure of eyelids to cover the entire globe. Topical drug toxicity, conjunctivitis, discharge conjunctival injections, eyelids stuck together or on awakening. Trichiasis, one or more eyelashes rubbing against the cornea. Entropion or ectropion, eyelid margin turned in or out. Okay, workup. History, trauma, contact lens wear, eye drops, discharge or eyelid matting, chemical or ultraviolet light exposure, time of day when worse, snoring or sleep apnea. 2. Evaluate the cornea, eyelid margin, and tear film with fluorescein. Evert the upper and lower eyelids. Check eyelids closure, positioning, and laxicity. Look for inward growing lashes. Inspect contact lenses for fit and for the presence of deposits, sharp edge, and cracks. Treatment. See the appropriate section to treat the underlying disorder. SPK is often treated non-specific as follows. 1. For non-contact lens wearer with a small amount of SPK, artificial tears, QID, preferably preservative-free. Can add a lubricating ointment, QHS. Non-contact lens wearer with a large amount of SPK, preservative-free artificial tears, Q2H. Antibiotic. Consider a cycloplegic drops for relief of pain and photophobia. Contact lens wearer with a small amount of SPK, discontinue contact lens wear. Artificial tears 4 to 6 times per day, preferably preservative free. Can add a lubricating ointment QHS. Contact lens wearer with a large amount of SPK, discontinue contact lens wear. Antibiotic, fluoroquinolone or tobramycin drop 4 to 6 times per day. Consider a cycloplegic drop for relief of pain and photophobia. Follow-up. Non-contact lens wearer with SPK are not seen again solely for the SPK unless the patient is a child or is unreliable. Contact lens wearer with large amount of SPK are seen daily until significant improvement is demonstrated. Contact lenses are not to be worn until the condition is clear. Antibiotics may be discontinued when the SPK resolves. The patient's contact lens regime must be corrected or the contact lens changed if either is thought to be responsible. Contact lens wearer with small amount of SPK are rechecked in several days to 1 week depending on their symptoms and degree of SPK.